want to stand up and maybe move your, stretch up your hand or jump or something? No? Yeah, just for a second, just to just stretch, maybe let's do some jumping jacks. Try it, it will work. Just get up, do a couple. Okay, while you're standing up, can I just kind of get to know who is in the audience? How many of you are infection preventionists? A large number. How many of you are nurses? Okay, and how many of you are physician, nurse practitioner, or physician assistant? One. Okay. Okay, I have to change my talk then. How many are pharmacists? Ah, good. Okay, I'll keep my talk the same. So I was given the task of talking about managing common infections in the nursing home, and I'm going to try to make it kind of relevant to all the audience. It's a little bit hard to, focus on infection prevention and stewardship and pharmacy and prescribing at the same time, but I'm going to do my best in the next 35 minutes. Okay, I have funding from Pfizer that ended at the end of 2021. And the objective of my talk is to identify when treatment is needed for common infection syndrome in the nursing home and discuss the appropriate treatment for urinary tract infection, pneumonia, and skin and soft tissue infections. So we know that the nursing home population is at higher risk of infection because of multiple frailty, use of devices, recent hospitalization, and so forth. And we estimate the prevalence to be between 2.3 to 5.3 per 100 residents. And these infections are associated with high mortality and morbidity, rehospitalization, and extended hospital stay, and substantial healthcare expenditures. This is a result of a point prevalence study that we did with the CDC at doing one-day assessment of healthcare-associated infection and antibiotic use across 161 nursing homes in 2017. And you could see that focusing on antibiotic use, there are 3 infections, as Dr. Cernik said: pus, pneumonia, urinary tract infection, and skin and soft tissue infection are the leading diagnoses for use of antibiotic in nursing home. And we found that 8.2% of residents on one day were on antimicrobial. It's much higher if you have a device such as a urine catheter, or you are post-discharge from the hospital or have a central line. And we know from multiple studies that the use of antibiotic in this population could be inappropriate or unnecessary. I think we repeated this all day. I'm repeating it one more time. And some of the example is treating a positive urine culture or a positive urinalysis when the resident have no signs of symptoms of urinary tract infection, or treating a viral illness like a runny nose and a cough when there is no evidence of pneumonia, or treating a positive culture from a chronic wound, but no clinical evidence of infection. So I'm going to kind of go into all those 3, potential infection and trying to say, okay, this is more likely to need antibiotic, or this syndrome is not likely to need antibiotics. So, one of the reason, some of the reason is, as we mentioned multiple times today, is multiple Ds: diagnosis, drug, dose, duration, de-escalation. I think I'm going to skip since everyone talked about it today. And so as Dr. Cernik mentioned, antibiotic decisions in the nursing home are complicated. I started working with a nursing home around 2013. I came from the hospital, and I had no clue how different it is to treat someone in the nursing home. It was kind of eye-opening to see that kind of how the evaluations are done, how the tests don't come back very quickly, how a lot of prescriptions are done over the phone. So, and the other thing that I really did never expected is the turnover of staff, starting from leadership. Like we would meet with an infection preventionist on Friday, we call on Monday, she's no longer there, which is like, wow. So that really kind of affects everything, because if you have a change in your CNAs, they know the patients, and you have new people or you have agency, they don't know the patients, so that if there's any change in condition, it becomes much more difficult to assess, is this really a change that requires an evaluation? The other thing that I was also made aware of is how often the families are part of the decision, and how they push, for example, for someone to be treated for UTI because their mother just doesn't look good today. Or, they came in from the hospital and their urologist who always kept them on antibiotic, and they have been on antibiotic prophylaxis for UTR for 10 years. So all those things were eye-opening to me, and I think I realized it's very hard, that decision, the physician that have to make this decision when they're not on site, how well they know the nurse that's calling them, how well the assessment was done, and how well they know the patient, is all, kind of makes a decision, do you start or not start? And sometimes they say, okay, let's start because I don't know, I don't trust what's given to me, just in case. And we want to prevent this just in case, because it leads to harm. So, what you have, if you're going to improve any antibiotic, and you have heard it multiple times, you have to address all those challenges. You have to educate the nurses, for example, what are the signs and symptoms of UTI. You need to educate them, kind of what should be worried about a pneumonia, or what symptoms is a fall suggestive of a pneumonia, is when do you need to be concerned, low blood pressure, tachypnea, tachycardia. How do we educate them so they can make that assessment and relay this information to the registered nurse who's going to call the doctor? How well she's going to describe the finding is also important. We need to educate the families. I have gone to family and resident meetings. I didn't sleep the night before. But it's interesting, when you talk to them and explain to them why we need to change what we do, like how we used to overtreat urinary tract infection, and why we're not doing it now they're not much more receptive. And it's kind of amazing when you spend the time to explain why you need to do this differently now, that we don't really have many antibiotics to treat. There is C. difficile, it can result in diarrhea. They're much more receptive. So probably target them when their loved ones are not sick. There were also residents in the room, and they were kind of amazed. Like the last time, I had a pneumonia, I was treated with this huge, big IV antibiotic, and this time I'm also only getting oral antibiotic. So, talking to everyone about what's your plan moving forward, because we're seeing a lot of antibiotic resistance. We don't have a lot of antibiotic, is also very helpful. And so, let's talk about urinary tract infection, which is really the most common indication for antibiotic use and the most common reason for bacteremia. And it's really the most common reason for inappropriate antibiotic. And the reason for it is kind of hard to differentiate between what's a UTI and what's asymptomatic bacteriuria. Another indication of overuse is really UTI prophylaxis. And we really don't have evidence that prophylaxis is really beneficial in this population. Is more likely to result in antibiotic resistance. So in some of the nursing home I work with, we really tried hard to identify people on long-term prophylaxis and try to talk to them and their family and try to stop their prophylaxis. Sometimes you have to really work very hard with the urologist or their prior physician, but we try to do that because that's a big burden of DOT, days of therapy, because you're receiving it every day. And so UTI, we had to explain to everyone, it's a clinical diagnosis. It's not just a positive culture or a urinalysis. So you really need to have urinary symptoms to have a urinary tract infection. If you don't have urinary symptoms, you don't have a urinary tract infection, unless you have a catheter. Because if you have a catheter, you can have urgency, frequency, and so forth, but there are other signs that suggest this infection. So this is the first thing that we had to educate people. So when you see a culture, when we reviewed chart, for example, it was just amazing to see there is an order for a urine, there is a result, and when the result came back, there is an order for an antibiotic, but there's no evaluation by anyone. So I sat in the room and I said to the people, okay, I reviewed all the charts of people treated for UTI, and I noticed that, when the culture comes back, you treat, but you go back to see if that patient is still symptomatic, and I had blind stares. So I think my message went through that, we need to look at the urine and look at the patient. We cannot just look at the urine. It's much better not to get that urine, because if a urine positive, we, the prescriber, have a hard time looking at the 100,000 E. coli and not treating. It's really hard. So it's much better not to get it if it's not needed. So it's really important to evaluate who needs a culture in the first place and who needs to be treated. Because a lot of people in the nursing home, I asked the CNA, do you know if you got cultures on all your women today, how many would be positive? And they were amazed to hear that at least 50% of the women in their facility, if we culture them, would be positive. So a positive culture doesn't mean that you have to get UTI. If you have a negative culture or negative urinalysis, yes, you can rule out UTI, but you cannot rule in without sign and symptoms of a positive, urinalysis or urine culture. And if you have an indwelling catheter, 100% would have, organism in there. And pyuria could be present with asymptomatic bacteria. So if you do a urine dipstick and you have, white cells, or you have leukocyte esterase or nitrites, it doesn't mean, it's a UTI. It means if you culture, you're going to grow something, but you have to look at the patient. So the message today, don't look just at the culture. Look at the culture with the patient. Don't get the culture if there's no sign and symptoms. I guess we got it right this afternoon. And, the people say, okay, so what's the harm? Their culture is positive. Maybe if I treat them, they would not get the UTI in a month. It's not the case. It doesn't happen. It doesn't prevent you from symptomatic episode in the future. It doesn't prevent bacteria. It doesn't improve incontinence, and it doesn't improve survival. What it might cause is more harm, adverse effect, recurrent infection with more resistant bacteria, and increased cost. So we shouldn't do it if we know that someone just has a positive culture. And then, what is important in a nursing home, and we have heard it multiple times, we really need to have protocols and flow charts, or when should you test someone and when should you treat. And it's interesting, as I was learning more about UTI, that there's really no standard definition. There are urinary symptoms, but how many you need and what else you need, and it varies, and it's all based off consensus. So I have here some example. I listed them here. So the McGeer criteria, or the updated Stone criteria, are more for surveillance, and they include a lot of signs and symptoms, which I will have in my presentation, the updated presentation. You can look at it. But the thing is, it requires a positive urine culture. So it's after the fact. It is good to see if someone who was treated, did they have signs and symptoms, and was the culture positive. It's not really used for your judgment to start someone on antibiotic, because someone might be treated before that urine culture is back. And those are, using the more appropriate use of the criteria are the low minimum criteria. And they rely also on the presence of signs and symptoms, fever, and so forth, to make a decision regarding treatment. And Dr. Cerning discussed his algorithm and discussed, to take into consideration urinary symptoms, but also look for flags, but that someone is quite sick. They have hypotension, they have fever, they have rigor, and those really are more suggestive of upper tract disease and not just a plain cystitis. And for those, you don't need to wait, you need to treat. For a plain cystitis, sometimes you might wait for a culture to see if there's something, but for someone who's that sick, you need to be treated empirically. And there is also the IOU consensus criteria for uncomplicated cystitis, and they had a consensus about what constitutes cystitis, how can you differentiate it from upper tract disease, and they have consensus of treatment for cystitis. And I have the references in the bottom, and I'm going to talk a little bit about it. It has a lot of information that are also useful in addition to the Cerning algorithm and their toolkit. from Wisconsin. So here I have a summary of all potential, signs and symptoms that are urinary that people have used. So without a catheter, dysuria is a very, significant sign. Fever, you should have fever with something else, not just fever. It should be fever with urinary symptoms. It could be urgency, frequency, suprapubic pain, gross hematuria, costovertebral angle tenderness, urinary incontinence, and it has to be a change in urinary incontinence, scrotal or prostate pain. And as I said, for resident with a catheter, you really have to rely on systemic symptoms like fever, rigors, hypotension. You can also on exam find out if they have CVA tenderness or suprapubic, tenderness or pain. And there is also new or worsening delirium, and Dr. Cerning really, talked about delirium is sudden onset of confusion, disorientation, dramatic change in mental status. Use the CAM evaluation to see if they truly have delirium. And the resident with catheter would be what you probably would use for someone who has dementia and who is not able to communicate their sign and symptom. Look for the systemic, signs. And what's not there in those criteria is foul-smelling or cloudy urine. So we learned today that, that's really, it could be other causes. If fall, behavioral changes alone are also not, things that should make you think of a UTI. So when I met, for example, with CNA and said, we no longer think of foul-smelling and cloudy urine as a UTI. They had also kind of an astonishing thing on their face. We do that all the time. We tell them if the urine doesn't smell good today, and then they get the urine. So this is something maybe useful to educate your frontline staff, when is it a UTI and when it's not. This is the IUU protocol. So what is needed, though, as everyone mentioned, it's helpful to have protocol in place for evaluation of a change in condition, including a change that suggests of a urinary tract infection. I know that this is very small to see, but basically, you follow and see if they have a urinary symptoms. You assess if they have any upper tract disease signs such as CVA tenderness, fever, and so forth. So you should be worried about an upper tract disease. This is more focusing on cystitis and when can you wait. And if you don't know if someone potentially have urinary tract infection and they're stable, what you would do is just do active monitoring and see what happens. And communicate to the family that active monitoring is not doing nothing, it's just watching them to see if something develops that can help you make a decision if this is urinary tract infection or this is a pneumonia or this is some other source, because you don't want to treat the urinary tract infection with like nitrofurantoin and they have a pneumonia where nitrofurantoin is not effective. And so the other thing that's very important is to have really better evaluation and assessment by the frontline staff and better communication with the staff when they're not on site. And this is a tool, the SBAR tool from the AHRQ, that you could see, the nurse would document if there is fever, if there is, pain, rigors, and so forth. And this might be helpful to when they assess to see if these are present and to communicate with the physician. And, we have tried to tell the nurses that are calling, if you really think this is not a UTI, say, they have none of those criteria. Doctor, I don't think we should get their urine, which is really a little bit hard to do, but if you have a medical doctor that's strong and say, this is what we're going to do, it's much easier to get the people to stand up and say what they think. Now, as I said, for people with cognitive impairment for UTI, you focus on objective finding, fever, hemodynamic instability, and leukocytosis. And if you're stable, you monitor sign and their vital signs and symptoms. And this is kind of a way to, this is from the IAU protocol, looking at kind of saying that even if you have people with cognitive impairment, if you spend the time to talk to them and evaluate them, you might be able to get some urinary signs and symptoms, and you might be able to examine them to see if there's any CVA tenderness, suprapubic tenderness that makes you think they have a UTI. So This is an example from our collaborative. We work with multiple nursing homes, and we focused on, educating physician and nursing staff about signs and symptoms of UTI. We had infection preventionists review people who are treated for UTI or who had a urine culture to see if they fit the McGear criteria, and then evaluate if someone really is on an antibiotic that is, covers the organism or not. And in some nursing home, the IP worked with the consultant pharmacist or with a medical director. If something is really, they realized when they did the review that the antibiotic was really not covering the organism, they went to those to give the feedback, or they were allowed to give the feedback directly to whoever prescribed the antibiotic. And what we saw with time, with the education and those tools, that the testing for urinalysis and culture decreased, and with that, we saw a decrease in the treatment of urinary tract infection. And so as far as management, I think I should emphasize, which we also realize when we talk to the people, how often do they get a good sample? In women in a nursing home, I'm sorry, but you really need a cast specimen to have a clean specimen. So that's kind of something that is labor intensive, and it's probably painful for the person. So it's really important to evaluate, is that urine is really necessary to obtain? And for people with a catheter, especially if it's beyond 2 weeks, they need to have the catheter changed. Otherwise, you're culturing whatever is colonizing that catheter. So we treat empirically based on the antibiogram and review a prior culture. If someone has ESBL a month ago, the person who's going to treat needs to know that this person had ESBL before they're not going to treat based on the antibiogram. It's important to look at the renal function, the allergy to make, and potential interaction to see what you should choose. It's important to review culture result once available, and if possible, narrow the antibiotic regimen and optimize the duration for treatment. These are all very important. So this is an example of an antibiogram from one of my facility. What I want to highlight, so some people might not be familiar, how to read it. You could see on the left side, the organisms are listed. You could see the most common, this is a urinary antibiogram. The most common is E. coli. And you could see if you look at ciprofloxacin, I cannot see very well, but it's not the best drug. It's like 65% are sensitive, and that's we commonly see in all the nursing home. So quinolone are no longer the first-line agent for treatment of urinary tract infection in the nursing home. You could see that trimethoprim sulfa in this nursing home is good, is 90% of the E. coli are sensitive, and you could see other agents like nitrofurantoin is 100%. So we had to educate the provider because they were reluctant previously to use nitrofurantoin, that nitrofurantoin could be used for a cystitis, lower tract disease, if the creatinine clearance is above 30. Now, in some facilities that are very small, they could not do the antibiogram because they didn't have enough sample. What we ended up doing is we worked with a lab to generate a citywide antibiogram for nursing homes that are less than 200 beds. And that was very helpful to see kind of what's resistant in our community. And it's not as good as this. The bacterium was lower than 80%. So then bacterium might not be an agent that you would use empirically in those facilities. And so for cystitis, or we call lower urinary tract infection, these are from Dr. Ashraf's document, and summarizing kind of the empiric treatment recommended. The first line now is nitrofurantoin and trimethoprim sulfa. And trimethoprim sulfa, if you have an antibiogram and shows that it is sensitive, your most common antibiotic organism is sensitive above 80%. The second line is a beta-lactam, cephalexin. Of note, cephalexin is bioavailability in the urine. 70 to 100% of the drug is excreted by the urine, so you have high level in the urine. And then the third line is phosphomycin and quinolone. Phosphomycin, an agent that is, covers some resistant organisms. So someone who has ESBL is in the bladder, it could be a choice, especially if your lab is able to do sensitivity instead of sending them to the hospital for IV antibiotic. And quinolone should be the last resort But you could use them if someone is allergic and you can have no other options, and if you have a urine culture that shows that this is sensitive. An alternative, this is from the IOU, they kind of have protocols, and they have kind of pocket card that you could use where they base their decision depending on the creatinine clearance, and they use ciprofloxacin, fosfomycin if you couldn't use the nitrofurantoin and trimethoprim sulfa. Now, for pyelonephritis, really you don't have many choices. You couldn't use the nitrofurantoin because it's not for upper tract disease, it's only for cystitis. So we usually recommend that you would give a dose of ceftriaxone. If they have history of more resistant, you probably use an agent that covers what they had before. And then you could use trimethoprim sulfa, ciprofloxacin, levofloxacin, or a beta-lactam. Beta-lactam are kind of less favored for upper tract disease. And then this is kind of a list of what are the choices and the duration. So most of the cystitis is like 3 to 5 days in women, it's 7 days in men. For the upper tract disease and patient with catheter-related UTI, 7 days if they got better. So we're aiming short, 3 to 5 days, 7-day maximum. Sometimes you have to go to 14 depending on the agent or if they didn't get better. So then I'll transition to respiratory tract infection, which is the second most common reason for antibiotic in the nursing home. What's important for respiratory tract infection, really, the biggest thing is to try to differentiate between is it viral or is it bacteria? And I know it's not easy to do. We in the hospital even don't know if someone has pneumonia or not, even despite everything, the CTs and everything. So I divided it here into upper tract disease and lower respiratory tract infections. So most of the upper tract disease are truly viral, like runny nose, sore throat could be bacterial, strep throat, but could also be viral. Sinusitis, usually it's viral, but could progress if people don't get better, could eventually be bacterial, but most of it is viral. Otitis media now, and we know very well it's viral, so people, the kids are not treated immediately. Lower tract disease is what we call bronchitis and pneumonia. And bronchitis tend to be due to viral illness, and there's no benefit in treating in people who don't have severe COPD or some other reason. So bronchitis is something to differentiate, that's important to differentiate from pneumonia. Pneumonia could be, sometimes it's very hard to know if the pneumonia is an RSV or COVID or it is bacterial. Most of the pneumonia are bacterial, but a large proportion in the nursing home could be viral. It could be RSV, could be influenza, could be COVID, could be parainfluenza. Without testing, sometimes it's very hard. And so I like this Dr. Kabani shared this with me. You could have this as a poster on your nursing unit, kind of when should you treat and when should not treat, because it could be viral or it could be, bacterial, when should you treat? So for COVID, we learned that there was a lot of treatment for COVID infection, but we know that bacterial infection with the initial infection is very low. So COVID patients should really not receive antibiotic with their initial infection. And I hope they're not being treated with antibiotic, but they're treating with, kind of monoclonal antibody or Paxlovid or some other agent at this time. Now, how to differentiate bronchitis and pneumonia? Bronchitis, you could have a cough, and the cough could be up to 3 weeks, which is frustrating. I don't know if you ever have like a cold and your cough doesn't go away. But usually you don't have, infiltrate on your chest X-ray. You can have some bronchial thickening on the chest X-ray, but you don't have an infiltrate. And many people can have wheezing. Presence of sputum doesn't mean it's bacterial. So you could have a viral illness, you could cough, you can have a sputum, but you don't have anything on exam or a negative chest X-ray. You really don't need to treat this as viral. And treatment, there's no benefit to treatment. For a pneumonia, usually, there is, more fever, more sputum production. There might be pleuritic chest pain, there's hypoxia, and usually the chest X-ray is positive. It's very important to know, though, that a chest X-ray with no sign and symptom, if it's interpreted as maybe infiltrate, many times it gets treated. So it's also recommended not to get a chest X-ray if you're not highly suspicious of a pneumonia, because you might find something and it might make you treat someone who doesn't really have a pneumonia. So some people say chest X-ray is your analysis of the lungs. So they have to be, they're not perfect. They have to be compared to their prior film. So it's important when you get it, make sure that someone have respiratory symptoms, hypoxia, and it helps you differentiate between, could it be pneumonia or could it be something else. And so for treatment of pneumonia, as the physician, we have to try to differentiate between kind of viral pneumonia, bacterial pneumonia, which is commonly aspiration pneumonia in a nursing home, and pneumonia due to MNDRO. The pneumonia kind of are common in infection, and they're the leading cause of mortality and the primary reason for resident transfer to the hospital. It's a common reason for people with dementia, at the end of their life to probably die of pneumonia. So it's very important for goal of care to be discussed for dementia patients. If they develop pneumonia, do you want to be treated? Do you want to go to the hospital? Because treatment at the end stage dementia really is not very helpful. It just prolongs their kind of agony, I would say. So for a diagnosis of pneumonia, similar to the UTI, the bedside diagnosis, people say maybe pneumonia doesn't present in old people with cough and respiratory illness. They do. Most of the people who have pneumonia have respiratory symptoms. So cough is common, shortness of breath. You could look for, respiratory rate about 25, is sensitive and specific. A pulse oximetry that shows that you have hypoxia is also sensitive and specific. And abnormal chest exam, I don't know how often, the nurses, before calling physician, are able to listen. If you have wheezing, it's probably more viral if they can hear something else. But I think it's probably difficult in your population to really assess. But if there is anything that you could hear that's different, it might be helpful to make the diagnosis. And the workup, I cannot emphasize, we have learned from COVID how important to check for viruses. We're seeing flu and RSV in summer, which we never saw before. So at this day and age, if someone really have a respiratory illness, I would still culture for viruses, probably include RSV and flu, especially if you know that they're circulating in your community in addition to the COVID. White count is helpful, especially if it's elevated. As I said, chest X-ray is important. It's important to see if it's really different from prior chest X-ray is present. Legionella antigen, it depends. Do you have a good water system in your facility to treat, to prevent Legionella? Have there been any cases in your community? Have there been any other cases in your other nursing home in the area? Might make you probably check for Legionella, especially if it's bilateral pneumonia and someone is quite ill. The role of procalcitonin is unclear in the nursing home. So when do we treat? And these are the Lopes criteria. They're very hard to follow. They rely on temperature and sign and symptom, but most of them have respiratory sign and symptom plus or minus fever. So this is what I usually use to make a decision if someone potentially could have a pneumonia or a COPD in exacerbation. For a COPD to be treated, you need to have dyspnea, increased sputum, and increased sputum purulence. And so what do we treat? There was a debate, what agent should be used. And we kind of realized when I went and met with my nursing home, they were really not using broad agent. So the treatment is focused, most of the organisms are really the organism that circulate in the community. So pneumococcus is very common. And so we treat like community-acquired pneumonia. We leave the broader agent for MDRO in people who have severe illness or they don't improve or have other reason to have MDRO, are known to have MDRO colonization and so forth. And as I said before, it's important to consider goal and care and see if someone really needs to be treated and transferred to the hospital. Now, what antibiotics to use? There are no guidelines that are out there for treatment of pneumonia in the nursing home. So we based our guideline. This is a Rochester collaborative. We came, multiple medical director and pharmacists came together and we decided what we're going to use. And I have the link in the end of the talk. There is also a document by Dr. Milot, in AMDA about treatment. They're very similar. So basically, we treat like we treat community-acquired pneumonia. And what we try to do also to put the quinolone second line, because we were trying to avoid the quinolone because of all the side effects related to the quinolone, and C. difficile. I will skip. And the duration, again, is short, 5 to 7 days, if, if there is clinical stability, which I have listed here. So short, short, short. And that's really will decrease the amount of antibiotic use to go short. For skin and soft tissue infection, I think, does anyone to guess from these three pictures, which picture, need to be cultured and treated? Put your hands up. Number 1. Okay, 2 people. Number 2. Okay, there's more, 4. Number 3. None of them. So the second one, maybe it's not the best picture. So this is the decubitus ulcer that doesn't look infected. There's no erythema. This is kind of just tissue there. Number 2 is a diabetic foot infection. So the person is febrile, there is redness, you can see there's some necrosis there. This person needs to be cultured and treated. The last one is just a decubitus ulcer, and there's nothing, there's no erythema, no drainage. So we shouldn't culture those ulcers, because if you're going to culture, what are you going to get? A lot of organism. And then it's going to be very hard not to treat. So if someone doesn't have redness, doesn't have fever, doesn't have a lot of discharge, purine discharge, they should not be cultured. That's the point today. So an ulcer doesn't include infection because there is a high rate of colonization, so you need to have increased purulence, you need to have warmth, redness, swelling, tenderness, and plus or minus fever. So the other thing I wanted to discuss is the cellulitis. The big thing that we try to push when we talk to the nursing home, bilateral cellulitis is very uncommon. And bilateral cellulitis probably reflects more what's called stasis dermatitis. And those can, ulcerate, those can have bullae, but you have to look at the patient and see if they have anything else that suggests cellulitis. With cellulitis, usually patients are febrile, they have pain, and it tends to be more unilateral. So we educate people that bilateral, think twice if this is a cellulitis or not. And the cellulitis, we have to look and see, is it just red or there is purulence? Is there like an abscess there or not? And that will make a difference to decide if it's strep or staph. So for a non-periodic cellulitis, we focus on treating strep. And so I have the agent there, which are oral, and we treat for 5 days. For a purulent cellulitis, we treat staph aureus. It could be sensitive or it could be resistant. There's no way to know, and you need to culture to see. And sometimes we go broad, covering for MRSA, and then we get the culture and see if we can change. And there, the duration is 7 days, with improvement. So in general, I want to close by saying improving the diagnosis and treatment of common infection in the nursing home requires a lot of effort because the prescribing decisions are very complicated. So what we need to do is make sure we have protocol for diagnosis and treatment in place. We educate nursing and medical staff about, who needs to be tested, who needs to be treated. We need to, implement communication tools such as SBAR and establish a process for post-prescription review. Many of the post-prescription review probably, could be done by the infection preventionist for something easy like a UTI, but for more complicated infection, it should be the consultant pharmacist. And having a process in place to have that review is very important, just to assess, or the nurse practitioner or the PA or the physician. Someone needs to see the patient or to evaluate the culture after they're done to make sure whatever they did is appropriate and the patient is improving. And I think I have more list of kind of tools in there, including our website, which is the Rochester Patient Safety Collaborative. We have a lot of presentation. We have an antibiotic tracking tool and so forth. So take a look at it, and then I'm done.
Dr. Dumyati, Dumyati. That was a wonderful presentation.
Thank you.
I was intrigued when you were talking about addressing prophylactic antibiotics. So when I've worked with facilities, there's always one, and I was wondering kind of how you operationalize that. Where do you start? Do you talk to the prescribing physician? And maybe what are some of the words you use to begin to address that, especially for the nurses in the room? I think that's a tough thing to try.
It's a tough decision even for physician, and we're not 100% able to stop it. And it's a conversation. So what we did in our nursing home, we flagged for the medical director who was an antibiotic prophylaxis. And the medical director went and assessed those patients and then talked to the family and the resident and say, look, we have learned that there's really no benefit, that what we're doing is causing more harm, more resistance, and there is now a push to stop antibiotic that are used long term. We will assess if it doesn't work and things get worse. And sometimes you cannot, have acceptance from day one, and it's have to be back and forth conversation. Sometimes it might require, if it's used by the urologist, to talk to the urologist. Sometimes you're successful, sometimes it's not. So from, most of the nursing home that tried to do it, maybe 50% of the patient, they were able to stop it. And some of them, they said, we gave up. So it's not something easy because we have, people have been on it for years and they swear by it. And so you just have to talk to them and explain that we are at a different time now, we know more, and we really need to change what we do. And sometimes they're depending, of the trust. So this couldn't be done in post-acute patient, post-acute care, because you don't have that relationship. It was easier to do it in the long-term population. The post-acute, I was told by the medical director, we cannot change them. They're here for a short period of time. We're not going to tackle it. We'll let it go.
Thank you.
Quick question and comment. How do we better communicate them with our family members? Because there was a previous question I think Angie had brought up with our families, because I'm telling you, they do not have the mindset that shorter is better. Is anybody else experiencing that? That if they see an antibiotic prescribed for only 5 days, well, no, shouldn't we make that at least 10 days to make sure we're rid of the infection? And so the other thing too is I appreciate all the grids up there for education. I think the simplicity will help us better educate our families. I know most of them do not know the difference between an upper and a lower UTI. So the more that we can educate them, the better it is.
Yeah, so in our collaborative, what was done, it was multi-pronged approach. So the nursing home sent a letter to the families saying, we are starting an antimicrobial stewardship program. We are going to change the way we prescribe antibiotic because of the increase in C. difficile and the increase in antibiotic resistance. So you might see that we use shorter courses. We might see us using different type of antibiotics. So they kind of primed them. And then we had also on admission, in their admission package, we have the letter as well. We also had a pamphlet about, when should, your loved one be treated for UTI. And then there was, we worked with the CNA and the nurses to talk to the family if they have a change of condition, and they said to the family, we don't think this is an infection or a urinary tract infection. How do you kind of back and forth? How do you respond? What would you say? It's kind of needs some coaching and training because it's very hard. Even for us physician, you have to go at it and be patient and explain why it is and why it's not. So we had a video on our website, trying to say, okay, don't do it this way, do it that way. And it's not easy. It takes a lot of practice, and it takes a lot of effort and building that trust between you and the patient and their family.
I just have a quick question. I know mandelamine is not an antibiotic, but I just wondered,
Methenamine?
yeah, what your opinion was on routine flushing.
There is a study in the long-term care population that shows that is not beneficial, but I think in the outpatient setting, there is, people, say, find it to be beneficial. But there was a recent study in the nursing home where it wasn't beneficial for prophylaxis. Salman, you want to add anything since you reviewed it?
The literature was not supportive of the use.
Chronic use. Yeah, maybe short time, maybe not for years. Any other questions?